Hi, everyone. So, good morning, good evening, good afternoon, wherever you are. Good evening from Bangkok. So, thank you again for making time to join the PMAC webinar on migration, labor, and the health of a changing planet. First, a few things. I would like to share a few housekeeping rules for our webinar. So please keep in mind that this is an interactive webinar. So feel free to share your questions and get engaged through the Q&A box. We will be selecting questions along the way. And also, this session is recorded. We will also be taking pictures as well, but this will only be for organizational communication purposes. And perhaps just to add that the recording will also be uploaded to the PMAC website. Okay. And perhaps before we begin and I start introducing the moderator, perhaps I should also say hi to everyone. So I am Angela, and I will be hosting this webinar together with our moderator and, of course, our amazing panelists for today. So hopefully everyone can enjoy the webinar and gain insights as this webinar is important as a part of the PMAC 2026. Okay, so now I will start introducing our moderator for today. So I would like to welcome Dr. Timothy Mastro. He is an adjunct professor at the Gilling School of Global Public Health from the University of North Carolina. He is also a leader in global health science and medicine, following a 40-year career in the arena. Dr. Mastro formerly served as a chief science officer at FHI 360, overseeing the research and science-based programs conducted in the United States and 60 countries globally. So I would like to welcome Dr. Timothy Mastro. Tim, the floor is yours. Thank you.
Great. Thank you very much, Angela. Thanks for getting us organized here. I'm really thrilled and delighted to be moderating this session for PMAC. So as Angela indicated, I'm calling in from Chapel Hill, North Carolina, where my university is based. So the prestigious Prince Mahidhan Award Conference, or PMAC as it's known, has been organized as a meeting of global experts and stakeholders held in Bangkok since 2007, focusing on policy-related public health issues of global significance. PMAC strives to identify actionable steps to improve global health equitably. The Prince Mahidhan Awards for outstanding achievements in medicine and public health worldwide have been conferred since 1992, and they're a key aspect of the PMAC conference. Several Prince Mahidhan Award winners have gone on to win a Nobel Prize in chemistry, physiology, and medicine, so the Prince Mahidhan Awards are commonly referred to as the Nobel Prizes of Asia. So the theme for PMAC 2026 is navigating global demographic transition through innovative policy and equity-centered approach. So as we all know, we find ourselves in a world undergoing unprecedented demographic changes as well as profound climate disruptions. Today's webinar covers one of the most important PMAC subthemes: migration, labor, and the health of a changing planet. Now, during the main PMAC conference, there'll be a 2-hour in-person session on this topic on January 30th. Today, we're fortunate to have on this webinar 3 of our distinguished session presenters. This webinar will serve as a preview of the main conference, which we hope will stimulate your interest, generate some buzz around PMAC 2026, and we hope that many of you can attend. So now I'm going to introduce our 3 speakers. First is Dr. Poonam Devan, who is the director of the Migration Health Division at the International Organization for Migration, IOM, in Geneva, Switzerland. In this role, Dr. Devan provides strategic leadership and oversees all migration health programs. She's responsible for IOM's migration health policies and represents IOM internationally, working closely with member states, UN agencies, and other stakeholders. With over 2 decades of international health experience, Dr. Devan trained as a medical doctor at the University of Mumbai in India and has further specialized training in health administration and public health. She will serve as our keynote speaker both today and at the main conference in January. Next up today will be Dr. Betty Barca, who's an international development specialist from the South Pacific with over a decade of experience advancing gender equality, disability inclusion, and climate justice across Asia and the Pacific. She currently serves as technical advisor on gender, equality, disability, and social inclusion with Save the Children in the Pacific. Her PhD from Monash University in Australia focused on the gendered impacts of climate change mobility in the Pacific. And she is also one of the co-authors of the Pacific Regional Framework on Climate Mobility. So she's really at an important juncture of these issues we're talking about today. Our third speaker will be Dr. Nguyen Lin, who is a medical doctor and public health professional from Myanmar, serving as head of programs at Dreamlipens Foundation in Thailand. He oversees two key projects, the Migrant Fund, M Fund, that we'll hear about today, and C Free, a community-based implementation research project of testing and treating persons with hepatitis C virus infection. Before joining Dreamlipens, Dr. Lin worked with UNAIDS, the Clinton Health Access Initiative, and the Luxembourg Institute of Health. Dr. Lin holds an MBBS from the University of Medicine II Yangon and an MPH in epidemiology from l'École des Hautes Études en Santé Publique, the French School of Public Health. So we're delighted that we have these three distinguished professionals with us today, and it's over to Dr. Poonam Devan now.
Thank you, Tim, Angela. A big thank you to the entire organizing team for PMAC 2026. And as Tim said, it is indeed a pleasure to be able to also participate today in this virtual webinar. My remarks coming from the International Organization for Migration will focus on the key theme, the sub-theme rather, of migration, labor, and the health of a changing planet, providing a broad overview of this very important topic and key intersection with public health. And hopefully this also generates more conversations during PMAC in Bangkok and enables us to have a very interactive discussion during the conference itself. I'm joined by my colleague, Michaela Told, who will also be assisting us today during this presentation. So when we think about global migration, from the latest statistics that the UN has published, about 1 in 8 persons worldwide is on the move. So, thinking of international migrants, this comes to just over 300 million, or 3.7% of the world's population. And as several of us who work in medicine, in public health, in migration, and also in social sciences writ large, several of these individuals are often more vulnerable to facing health challenges. These could include both mortality and morbidity risks due to various health and disease conditions caused by many factors, such as language barriers, limited access, and other impact caused by displacement, which we will go over in more detail in the ensuing slides. Amongst those on the move internationally, and in responding to the topic of our webinar today, let's also see what the latest ILO statistics mention vis-a-vis the labor force. So as you will see from the published data that we have included here on this slide, there are, of course, several international migrants in the labor workforce, around 167 million, to be precise. And of these, nearly 70% are estimated to be working in the service sector. This includes health and related care, as well as domestic work. ILO also estimates, based on available research and their own work, that there still remains almost a 25% pay gap when we think of the labor workforce in a country between migrant workers and national workers. And of course, there can be an almost 3 times higher risk of forced labor for migrants. And this can take in also IOM's own experience many forms. This could be situations of forced bondage, but it could also include exploitation as well as discrimination and abuse that migrant workers can face, especially in the informal sector. And then we can easily infer from even these data how there can be unique health-related vulnerabilities, but also some unique opportunities that migrant workforce presents in terms of public health. It's important when we discuss health and migration that we bear in mind what enables and also motivates or serves as an impetus for migration, especially international migration. Of course, in public health, we often speak about the various socio-economic, socio-political, cultural, and other determinants of health that go beyond simply disease risk factors. And we like to often say that migration in of itself can also be a determinant of health. It can influence health outcomes, not only at the individual level, but also at the social and community level, which is why it is so important also for a public health conference such as PMAC to factor in the role of and interconnection with migration. As you will see from the graphic on this slide, we look at both micro as well as macro drivers. We look at individual and economic drivers of migration. We also have the political as well as environmental drivers. So, to put it very simply, it can be individual motivations, family ties that lead to migration for some. And for some communities, climate change and natural disasters can be the impetus for migration. Conflict and crises often also lead to forced displacement, contributing to huge numbers also of internal migration. So, as you can see, migration and its drivers are an extremely dynamic concept, a complex set of interlinking factors that can influence the decisions related to migration from one location to the other, and then also sometimes circular or return migration. And increasingly, there is a lot of change, a lot of further dynamism added when we think of recent years vis-a-vis the phenomenon of migration all of which intersect then with health-related outcomes. We are also, of course, not so far away from the world having faced a pandemic such as COVID-19. And even anecdotally, I am sure several of you attending today are aware of how population mobility was both impacted during the pandemic, for instance, through border closures, but also the health of migrants and mobile populations themselves faced heightened vulnerability around access and continuity of care issues. So on this slide here, you will see from IOM perspectives, some of the very pertinent and most present factors that are influencing migration. Let me just quickly mention or read through these 6 points. We look at global hardening of migration policies, which can result in shrinking of legal migration routes. There is further transactional international engagement, and we are also witnessing this, unfortunately, in global health with further streamlining or reduction of donor funding. There continue to be, regretfully, many conflicts with new dynamics, resulting in higher displacement and straining existing responses, whether it's in health systems, but also in the broader socioeconomic systems. We have, of course, both the pros and cons of the very rapid developments in artificial intelligence and also technology overall. And this creates both opportunities, but also creates risks of misinformation. And then we also have the continued economic tensions as well as climate change related factors that are influencing migration. Next slide. So in this context, of course, we are also seeing mixed migration flows where, as I mentioned before, migration is not just a unidirectional phenomenon, but tends to be circular, tends to have many different motivations or drivers. And I hope that during the session in January at PMAC, we'll be able to dig deeper into some of these and have a bit of a discussion with the audience there on the impact on health, which is precisely what I'd like to go over briefly now in the second part of today's presentation as to why migration matters in health. We are talking about migration and health because population mobility becomes very critical to country level health operations and impact, addressing very importantly national but also regional and global health security. I've mentioned how migration is a determinant of health and bridges many different sectors. We also have this approach in IOM's own work. And health can also serve as an entry point to address the needs as well as advance the global and regional migration related work. Without going into all the details, we wanted to flag here the intersection of migration health and the many different factors that influence the health of migrants, but also communities when we speak about the pre-migration, during migration, as well as arrival and post-arrival phases. In light of this context, IOM follows our strategic health focus along the 3 strategic objectives that the organization has overall. This includes saving lives and protecting people on the move by improving access to quality healthcare and provision of health, but also psychosocial services. Number 2, strengthening of health systems, as well as anticipating and mitigating health-related risks in order to deliver solid solutions to displacement. And number three, promoting the health and psychosocial well-being of migrants and people on the move, including the provision of direct services and integrating health governance so that individuals can access pathways for regular migration. Looking ahead, when we think of achieving SDG 3 on health-related goals and targets, or also achieving the many health goals that member states, governments, as well as other partners have, migration will be central to both future workforce as well as health and care needs, which means that we have to focus on building migrant inclusive health systems that can strengthen response to health-related needs posed by population mobility. We'll also dig a bit deeper in January into how health workforce mobility, when we speak about labor migrants, can also actually be an opportunity to further strengthen health systems while contributing to labor migrants, and how there is a need for coordinated governance and stronger cross-border cooperation to achieve global health goals. I'll be digging deeper also during our session during PMAC into how this interlinkage means that public health practitioners have to look at three agendas: the global migration agenda, including Global Compact on Migration and Refugees, for example, the development agenda, SDGs, but also bilateral and multilateral development goals, and most importantly, the global health agenda, the various World Health Assembly resolutions and UN commitments on health. All of these require a reference point when we think about migration, health, and labor in a changing global environment. Some of the key priorities in this context can include navigating political contexts and policies to overcome barriers to access. It can mean continuity of care and how we can bring together sending and receiving countries and communities, or addressing very operational health work, vaccination, disease surveillance, amongst others. I'd like to leave you as well with some more detailed points, as I mentioned, around looking at health systems and workforce mobility in the context of the global shortage or disequitable distribution of nurses and care workers, and how we can overcome some of these let's say, challenges and transform health workforce mobility as well into a positive force in thinking of health and migration. I'll stop here. And as I mentioned earlier, really looking forward to this piquing your interest and also serving as setting the stage for a more in-depth and interactive session during the conference in January. See you in Bangkok. Thank you.
Dr. Poonam, thank you so much for a really brilliant presentation. We always wish we had more time. We will in Bangkok have a full 2-hour interactive session. And I should note that the PMAC conference goes on for 3 days, and then there are 3 days of pre-meetings for those that can make it to Bangkok. So there'll be ample time to elaborate on this. And after the 3 speakers, we'll have a discussion session where we'll discuss among the presenters, and there's also an opportunity for the audience to pose questions. So now we'll turn the stage over to Dr. Betty Barca. Betty?
Thanks, everybody. Hi, all. Dr. Poonam has absolutely laid an excellent global overview of where things are for moving futures, migration, labor. And so my very simplistic 5-minute intervention is going to bring you to a particular sub-region of the world, which is the Pacific. And that's where much of my work has been undertaken over the past decade. And I will showcase some of the evidence that has been gathered through my PhD, primary data, but also through the work that I have done alongside IOM and its stakeholders in the sub-region in developing the Pacific Regional Framework on Climate Mobility. So the Pacific Regional Framework on Climate Mobility is one of the two, if I'm not incorrect, but Dr. Poonam and team can correct me, is one of the two sub-regional frameworks that actually acknowledge the impacts of climate change on migration and human mobility in general. It is not a surprise to many of us, but climate mobility is already a lived reality across most of the Pacific, and much of the Pacific are small island nations. Key forms of movement do include staying in place for many of them. What other forms of movement look like are planned relocation, migration, displacement. One of the things that we are increasingly acknowledging is that these patterns of mobility are increasingly shifting from being voluntary to increasingly forced. And so Dr. Poonam's already covered robustly the key drivers of mobility in the face of the climate crisis and natural disasters. But across the region, the three key things that do keep coming up are rising seas, extreme weather, and ecosystem collapses. So that does mean that even those that are not living on the coastlines are finding it incredibly difficult to maintain livelihoods, access basic healthcare systems, or support or send their children to school. And so that is linked to the economic drivers, which are livelihood disruptions, include the need to move for labor mobility and then being able to support families on remittances. Political, I think Dr. Poonam has already spoken a little bit around this, but policy choices of the governments, the capacity of governments across the Pacific, planning failures, governance structures that continue to sort of reinforce particular ways of working that tend to disregard the evolving nature of the changing planet and what we need to do to adapt accurately. So one thing that the Pacific region leaders and stakeholders, academics, thought leaders have all acknowledged is migration is both a risk, but also a climate resilience strategy. And there is no singular way to look at it. It's not just people are moving because of climate change or because of natural disasters. It's because people live intersectional lives, and their experiences are informed by their intersecting identities, that this is what it is right now for different populations. The other core component is that cultural identity, sovereignty, and human rights remain central. I think, it's always super helpful to understand the global picture, but during my primary data in Kiribati, I remember being, talking to women in the evenings by the water, and one of the things they kept saying it haunts me every single time, is that we're going to live here and we're not going to leave because this is our home, but we don't want our daughters to live here, and whatever we can do to send our daughters out of this country is what we will do. And it showed that they didn't want to. It was not something that they wanted to do. Home was Kiribati for them, but seeking a better livelihood for their children was something that they wanted to do, and they knew it was not going to be found in their island home. And it as I said, haunts me till date, which also reinforces the work I do in this area. So the Pacific Regional Framework on Climate Mobility is an attempt to consolidate Pacific leaders' ideologies around this, take a rights-based approach, but one that is also culturally grounded. The framework does talk about accessible health infrastructure and services. It also speaks about intersectional and intergenerational approaches, which is directly related to the findings of my thesis, which we'll talk about in a bit. But it also talks about mobility, including the right to stay in place safely and with dignity. So my PhD, which is eventually going to be turned into a book, so please keep an eye out for that. But in a snapshot, some of the key findings were, I was looking at a case study of Kiribati in Fiji. I ended up only looking at Fiji because of border closures in my primary data collection. And some of the key things that came out of the thesis were that there were gendered barriers in relocation decision-making. So if you can see the image on the slide, you will know that Fiji as a government has decided to undertake state-led planned relocation efforts as a result of recognizing the impact of climate crisis on populations. At the time of doing my thesis, 7 villages were either completely or partially being relocated by the government. And it was state-led because there weren't other resources to support it. So one of the gaps, as I said, was gendered barriers in relocation decision-making. And that was also not only reflected in community settings, it was reflected in health and climate governance at the national level. There was poor planning, which created longer-term health and livelihood impacts. For instance, communities that actually relied on natural, organically grown produce were moved further inland, and they did not know how to cope with the shifts in their living situation, which then made them rely on overprocessed food, whereas initially they were completely relying on primary industries like fishing or growing their own foods and vegetables, which has also inherently got health consequences to them. Women and gender non-binary individuals were excluded in various ways. One of the things is in one of the communities that was the first village to be completely relocated in Fiji, there were homes that were built without kitchens or bathrooms that were built without doors. And so the implications of that I do not have to dive deeper into, but that demonstrated that women were not engaged in the decision-making. And if entire homes were built without kitchens, that shows the gendered impacts of what it means in leadership. The intersectional experiences, then again, I mean, I speak about gender in one way, but gender is just one of the multiple identities. A young woman would have very different experiences to that of a young man in that very same community, which often tend to be overlooked and does come with increased burdens of unpaid labor for women and gender diverse people. For instance, across my data, there was evidence that gender non-binary people were very much a part of the community when it came for celebrations, but the minute a disaster struck, there was no place for them to evacuate safely because they were considered to be the reason for the sins that the community was undergoing, all of these natural disaster impacts. So it was just all of these sociocultural elements that were linked to people moving and not acknowledging climate crisis as the cause. In a very simplistic summary of years of work, and something that we can definitely dive deeper into in Bangkok, is that climate mobility is accelerating. We are now increasingly seeing evidence of what that looks like. With health at the center, though, there are disrupted services, rising disease risks, psychological stress, and unequal access that shapes migrants' well-being. Health systems must adapt, integrated, coordinated across borders, and fully migrant inclusive within UHC. The other component of that is One Health, and that is something that we are all exploring, but also understanding what it means to be living in harmony with nature and the impacts of that. Mobility approaches must be grounded in rights-based and be gender responsive and socially inclusive. It is critical that we address gaps in the health and climate governance system that continue to recreate these structures that continue to overlook people who are most marginalized or historically have been marginalized. PMAC is an opportunity amongst many others globally of multilateral spaces where we can be viewing mobility as a chance to reimagine systems rather than recreate those that have been creating inequalities in the first place. There's so much hope that we can draw on, so much we can change, and we can do it now. And I think that's why PMAC serves as such a crucial juncture for us to have these discussions and dive deeper and build partnerships going forward. And that team is a snapshot from me. I look forward to staying connected with you all. Passing it back to you, Tim.
Well, Betty, thank you for an extremely engaging presentation. I look forward to reading your publications on this work that you've done in the future and seeing you in Bangkok in January for more in-depth talks. So we started off with a global view from IOM and then a regional view from Betty. And now we're going to go to a Thailand-specific view or regional view of a project from Dr. Nian Lin. Nian, take it away.
Thank you, Tim. So today I'm truly excited to be joining this section, and I'm going to share the M Fund, also known as the Migrant Fund, which help protect the health of the migrant workers in the context of Thailand and its border area. As Dr. Bunan mentioned, several factors come into play: climate stresses, economic uncertainty, and border conflict. And as Dr. Betty also mentioned about the gender disparity in the migrant health. So we would be learning more about the infant model. Next slide, please. So as you all know, Thailand is often cited as a success story when it comes to the universal health coverage because all Thai citizens have been covered. But the picture is quite different for migrants because Thailand is also the host country for the millions of both registered and unregistered migrants. Even though the national health insurance system are in place, there are still a significant proportion of the registered migrant. And on top of that, estimate 1 million unregistered migrants are uncovered by any national health system. So these are the workers who drive the economic factors and they work in construction, agriculture. So they face day-to-day occupational health hazard. And on top of that, climate change adds on to further pressure. Next slide, please. So in response, Dream Development Foundation, we created the Migrant Fund and Fund as a low-cost, non-profit health access fund directly targeted at the migrants who are not covered by any government schemes. So the idea is to enable the migrants to participate or contribute affordable small prepayment for their healthcare coverage. By doing this, we are trying to close the universal health coverage in Thailand. And at the same time, our vision is not limited to Thailand. We would try to gradually extend to the migrant, refugee, and border community in other settings in neighbor country as well. Next slide, please. So I'd like to explain briefly about how Enfront operates. We have essentially two pillars. So the first one is the community-based mechanism. So we have a team of the community workers. They go where the migrant lives and works. They themselves are migrants. And when they are interested individual, so the second pillar is the using of the digital technology. So we use the secure digital application to enroll the member voluntarily. And each member will receive a small QR code linked to the digital membership card, as you can see on the right-hand side of the screen. So the card essentially shows the plan benefits and the remaining coverage. Next slide, please. So when the member is sick, so what they have to do is they simply go to the partner hospital, they bring the QR card, and they show it to the staff. So the hospital, our partner hospital, they scan the code, and they will immediately see the benefit, whether the member is active or not, and they provide healthcare to migrants without asking for any documentation, without asking upfront payment. At the end of the month, at the partner hospital, they send the medical bill directly to us. And this direct relationship with public hospital is essential because it reduces the informal payments. At the same time, it builds trust among the migrant community. Next slide, please. So as we've been discussing previously, climate change is already affecting migration patterns, not only in the Mekong region, but also globally. More people are forced to move because of flooding, landslides, and border conflicts. So these same factors are making their life more difficult. They make their income more unstable and expose them to environmental and occupational risks as well. So what we offer is adaptive social protection. So even in crises like COVID-19 or border closure, our member could maintain the coverage and still have access to partner hospital. Next slide, please. So this is a snapshot of the MFAN project in general. So as of October 2025, we have over 100,000 members voluntarily join our MFAN program, and 63% of them are female who are dependent of the migrants workers. So I like to highlight also that we operate cross-border in two areas, one in Tak province opposite to Myawaddy in Myanmar, and one in Sakyao provinces opposite to Poipet city in Cambodia. So we work with more than 250 partner hospitals. Many of them are public facility, and we provided more than 170 outpatient consultation and over 21,000 inpatient admission. Here, I also would like to highlight that the gender dynamic as well. 70% of our service users are women, and 1 in 4 was pregnant at the time of the service use. Next slide, please. So I'd like to end with some of the key messages. So the first one is the community-driven and fund model complement the national system and help close the universal health coverage gaps. And secondly, we use the inclusive health protection as a fundamental human rights, but at the same time, it also strengthens the resilience of the migrant communities because they can have a saving for any external shock like environmental and economic stressor. And thirdly, because the migrants are highly mobile, cross-border collaboration is essential to maintain the continuity of care because people move across within provinces or across the border. And finally, we are able to generate the unique evidence on the migrants' change in demographic and their health needs influenced by the climate stresses. So these evidence and collectively can be used to inform the regional policy on migration, labor, and climate resilience. So that's the end of my presentation. Thank you so much for the attention. I look forward to the discussion afterward. Back to you, Tim.
So Nian, thank you very much. Since we've got you here, so we have about 15 or 20 minutes for questions and discussion. So I'd like to get some interaction among our three presenters. Let me start off with a question for Dr. Nian. How does the M Fund maintain continuity for care of mobile cross-border populations? And what comes to mind, of course, to follow the issues in this seminar, you have to read the newspapers every day to know what's going on in the world. So that the Thailand-Cambodia border has been a hot spot of disruption. How do you maintain continuity of services in settings like that?
Thank you for the question, Tim. Any border issue has impact on our project and at the same time to our members. So to maintain the continuity of care, so as I explained before, so we have the digital identity of our members. So each member has the QR code-based digital ID. Whether they move from one side to the other, they can just bring and show that to the partner hospital and they will receive the same amount of health care. And also another thing is to have a multi-province like a provider network within the public facility and at the same time with some of the private facility as well. And then we have our team of amazing community workers. So they do the close follow-up. They know the member really well. And we are using the digital application so they can see their members in real time who are about to drop out, who are about to move. So they know the reason and they can quickly follow up with the members. So our members do not lose protection when they move to the other side. So that's how we are trying to maintain the continuity of care.
Great. Well, of course, your presentation raises many issues for us, but we'll move on. I have a question for Dr. Poonam. Again, thank you for that remarkably clear and overview of what's going on in the world. In your presentation, you had a very gentle term, and it was the hardening of policies related to migrants. And behind that very soft term of hardening of policies are some really very unfortunate aspects of migration and anti-migration sentiments. So given those dynamics in the world and what's happened with global health, what has happened for funding for IOM, and how do you deal with as you put it, the hardening of policies towards migrants in the world?
Thank you, Tim. Of course, as it pertains the changing political dynamics, the changes in migration-related policies, as IOM, we continue to serve with and for our member states, that is the various governments that form the IOM membership, as well as the migration impacted communities, other stakeholders, including the private sector and others. The overall tightening of funding, whether it is in terms of the global health funding, but also in terms of some of the conflict-related preparedness and response-related funding, has, of course, also impacted IOM's ability, especially close to where our beneficiaries are. As several of you may know, IOM is also a very operational organization. We work hand in hand with our government and other partners. So indeed, it has impacted in certain parts of the world, IOM's scale and depth of programming and capacities to implement. At the same time, as I mentioned in my overview, we continue to work with purpose and continue to drive evidence-based recommendations in order to also show how working in an intersectoral manner, for instance, on labor mobility and health, working on climate-related displacement and disasters, as Barkha meant, how we can find ways to adapt policies to drive the positive potential of migration, while at the same time safeguarding the need to help those who may be most vulnerable. I would be happy to share a few case examples and also take more questions during our session in Bangkok. But really, the approach is one of using evidence, harnessing the positive potential, but then continuing to advocate to be able to bring services to those most vulnerable.
Poonam, thank you. And your last comment highlights really one of the most beneficial aspects of PMAC is it's a gathering of stakeholders and professionals for 3 days in Bangkok with plenty of time to have discussion both in the sessions, in the corridors, and a great deal of interaction. So I look forward to going much deeper on these issues with you when we meet in Bangkok in January. There's a number of questions coming in, and Angela, I'll ask if you, let's see, I'll ask Angela if you actually could pick out some questions, but I have one question for Betty that I'd like to get out. Betty, you talked about, a regional framework, and the South Pacific region is a very unique one in the world. It's rather large geographically, very diverse number of communities. How do you begin to coordinate a regional response to the issues you talked about, labor migration, climate disruption? What's the most effective mechanism you found to do that work?
Thanks, Tim, for the question. And I was going to say Dr. Puna might be better suited to answer this question, but it is because of decades of investment of organizations like IOM, for instance, that actually led that process. There are, for those that are not as familiar with the Pacific, there are multiple sort of agencies where government leaders get together and decide, for instance, they decide on climate change or peace and security issues or health or education. But these discussions do happen in silos. So they don't speak to each other that often. And we know that, where that's gotten us. So there was an ongoing effort by IOM who recognized this as a challenge across the Pacific and had dedicated about 10 years worth of programming, not particularly specific to climate mobility, but it was sort of a product that came out of understanding mobility patterns across the Pacific. And that, for instance, brought together the evidence that we needed to get buy-in from political leaders, and that inherently shaped the leadership of Pacific leaders. So by the time we were co-authoring the regional framework on climate mobility. We were in a room full of 22, Pacific Island leaders who were the leaders that we needed to talk to bring into a room. There was not a single person that was saying this is not the reality, we shouldn't be talking about it. So in essence, this is, while every single Pacific country is focused on climate adaptation and responding to disasters and all of the risks that come with it, this is an effort to mitigate what is to come. And it is also recognizing that there are positive ways we can deal with this. It doesn't have to be disastrous. It doesn't have to be, all of the negativity that's, carrying around the media. And so everybody in that room recognized that this is an opportunity for us to take ownership and agency of what it means for us when the time comes for us to make this difficult call. And I think that is the way we need to go about it. We need to invest our time and energy and effort into multilateral conversations to make sure that we're not recreating the wheel, but we're also not overlooking processes that have done good in the past.
Good. Well, thank you. And I would invite our three panelists, if you have a question for one of the other panelists, please just raise your hand and you can pose that question. Do any of the panelists have a question for the other panelists? Nian, go ahead. You have a question, please.
Yes, my question is for Dr. Betty Barker. Since you focus on the gender dimension in the migrants, and I'm curious that how gender disparities play a role in the migrants access to healthcare.
Absolutely. So I can have a go at it. And I feel like you are also the expert, Dr. Nian. You do this work day in and day out. So the countries that I focus on already have quite stretched healthcare systems. So the fact that, for instance, the country Fiji is quite possibly one of the few Pacific Islands that has, tertiary level healthcare and health coverage. But for countries like Papua New Guinea, primary healthcare is quite often the only form of healthcare that is available to many. And so even for inter-displaced communities, accessing that healthcare system was the only form of healthcare access that they had. And that is now super strained. It was strained to begin with. And now with shifts of people into these centers where people are moving into places where infrastructure exists naturally, which is that is aligned with global movements. So where there were smaller healthcare systems are now burdened with loads of people that are unable to access quality healthcare, where healthcare was, as it is, difficult to access to begin with. And I think for smaller islands, for instance, Tuvalu and Kiribati, you may have seen news articles. The main hospital is, when there's a king tide, the floor of the main hospital is actually flooded. So mothers are giving birth when there's water flowing on the ground during king tide. So the reality is that the impacts of these are quite tangibly viewed all the time, and there's only so much outside of infrastructure that is being prioritized by the government, but there is so much more we could be doing more meaningfully, right? So I think, and over to this group as well, I think Dr. Poonam and Tim would also have excellent insights on this as well.
Yeah. Well, thank you. We're getting a bit short on time, but there's one question that was posed in the chat that I'd like to throw out really to all three of the panelists. There's this issue related to an increase in political and legal barriers that are creating a more hostile and sometimes dangerous environment for migrants. What do we see as the most appropriate response to these kinds of dynamics? And perhaps we'll start with Poonam for that.
Thanks, Tim. It's a bit similar to what you posed earlier as well. And really, the first approach should be to bring forward evidence-based recommendations. We often see, for instance, around health-related topics, also when we talk about, let's say, disease outbreaks in cross-border areas, or as we saw during the pandemic response, There is unfortunately a lot of misinformation that can also lead to, sort of misplaced public perceptions, as well as result into certain policy decisions that may not actually be useful for the public health of the host communities themselves. So I would say that utilizing evidence-based recommendations is key to overcoming some of these barriers, as well as being able to show through solid analysis how making access to healthcare more equitable, reaching those communities that Betty Barkha was just talking about in terms of communities impacted by climate disasters. How can the public health community do better at monitoring and evaluation to show that this results in improvement of not only health, but also the social and economic outcomes in societies? So just a couple of suggestions in response to that question. Over.
Yeah. Thank you, Poonam. That's great, and we will have more time in Bangkok to talk about this. Let me give the last word to Nyan, perhaps. This issue again of the potential hostility and dangerous situations. I had the privilege of visiting one of your programs in northern Thailand on the Thai-Myanmar border last year. How do you address these issues of hostility and making sure your programs don't put people in harm's way?
Yes, that's an excellent question. And I mean, I don't have like 100% correct answer to that. But based on our project implementation side, for example, when we have a border issue on Sakyao and Phoi Phet, Thai and Cambodian border, it has a heavy impact on our day-to-day operation since the borders were closed down. And I see that the team on the ground, so one of the key area that we identify is the dissemination of the correct information in the area. So when the conflict happened, like people, the first thing they would do is go to the social media and they look at the different news, and it affect their willingness to go to the partner hospital. So our team act as a shock absorber or convey the messenger of the right information, because a Thai hospital are open to any citizen and they continue their service for any patients in general. But the people have different ideas or perception towards that. So we have to clear that information on the ground. And then another thing is the cross-border collaboration, as I mentioned earlier. So we have partner hospital on both sides. So even though the border was closed down, they can still have access to the hospital on both sides. I think this is one of the important parts that we have to address whenever there is a conflict in the border area.
And it's also quite impressive to see how well the M Fund is coordinated with the Thai governmental response. And the impressions I've got from the Thai Ministry of Public Health is not that they don't see M Fund as a challenge, they see it really as a complement to the services that the government's providing. Well, the hour has gone by incredibly fast. I really just want to thank our three presenters for giving us an insight into their vast expertise. We look forward to seeing you all in Bangkok for PMAC 2026. For me, this has been a really rewarding webinar. Angela, I'll turn it over to you for any closing comments you have, but just thank you to Poonam, Betty, and Nyan for really a very stimulating session to get us started. I'm so excited now about PMAC 2026, which is less than 2 months away.
Thank you, Tim. But I think before we close, for the speakers and the moderator, kindly stay on with your camera on. I will take a quick picture before we close.
Okay. But for the audience, thank you very much. Thanks for your questions and participation. Please help us spread the word. And of course, a recording of this webinar will be on the PMAC website. So those of you that weren't able to make the time, whatever time it is in the world where you are, you can look at the recording at the PMAC website in the future. So thank you all very much.
Thank you, everyone. I think on the screen you can see a QR code. I will also be sending this through email for your feedback. So if we are to hold any future webinars, we would greatly appreciate your feedback and input on this. So thank you very much, everyone, for joining.